Welcome back to Radong Smart Review GU Cancer Series. This is episode 6, prostate ADT integration from favorable intermediate to very high risk.
It is really great to be back for another tutoring session.
Yeah, totally. And, what if I told you that the single most consequential decision you're going to make for a high-risk prostate cancer patient isn't the radiation dose?
Right, or like the target volume.
Exactly. It's actually a temporary systemic medication that fundamentally alters their cellular biology.
Yeah, today we are talking about ADT and why understanding its integration with radiation is basically the bedrock of curing localized prostate cancer.
Over the last 2 sessions, episodes 4 and 5, we gave you the radiation tools.
We went incredibly deep into dose escalation, hypofractionation, SBRT, and brachytherapy.
Right. We talked about targeting, we talked about margins and protecting normal tissue. But as you already know from seeing patients in clinic,
Radiation alone is simply not the whole treatment story for most men with intermediate and high-risk prostate cancer.
it's just not. ADT, or androgen deprivation therapy, is the crucial systemic partner here.
So the mission of this session is to completely decode the risk group by risk group logic of ADT duration.
Yeah, we're going to explore how local and hormonal intensification actually complement each other.
And we will introduce you to STAMPEDE-style systemic intensification. We are going to look at the biology, the history, the trials, and, the exact board-ready answers you need to have locked and loaded.
But before we take a single step further, we have to establish one hard rule.
Oh, yeah. The absolute foundation.
I want you to burn this into your memory right now, because violating this principle is a fast track to failing your boards and, well, more importantly, harming a patient in the clinic.
Let's hear it.
ADT should never be used as monotherapy for clinically localized prostate cancer unless local therapy is absolutely contraindicated.
That is so important to emphasize.
Let me repeat that. You do not use hormone therapy alone to treat a localized prostate cancer unless the patient's medical comorbidities or, life expectancy completely preclude radiation or surgery.
Right, because it just does not improve cancer-specific survival on its own.
Exactly. All you are doing by giving ADT alone to a patient who could tolerate definitive local therapy is exposing them to severe toxicities.
Yeah, metabolic, cardiovascular, skeletal toxicities, all without any actual curative benefit.
It is a partner to local therapy, never a substitute.
I am so glad you emphasized that.
Yeah.
It is a really common misconception, sometimes even among referring providers, that we can just put an older guy on hormones and watch him.
Right, assuming the hormones will just take care of the localized tumor.
But they won't. They will suppress it, sure, but they will not cure it. And eventually that tumor will develop castrate resistance.
Yep. So mastering the when, how long, and what type of ADT is going to be one of the most consequential decisions you make in your practice.
And unquestionably one of the most testable concepts on your oral boards.
Absolutely. So let's ground this entire discussion with our case anchor. I want you to picture this patient sitting in your clinic right now.
Okay, set the stage.
He is a 63-year-old man with high-risk prostate cancer. You're looking at his MRI, and it clearly shows clinical T3, a disease.
So there is extracapsular extension.
Exactly. His PSA is 24. His biopsy results show grade group 4, which is a Gleason 4 plus 4.
And what's the volume like?
It's present in 7 of his 12 cores. He has been referred to you for definitive EBRT.
Okay, let's look at his imaging and his overall health profile before we make any decisions. You order a PET CT, specifically a PSMA PET CT.
Right, and it shows intense prostatic uptake, correlating with the MRI findings. But importantly, there is no evidence of nodal spread or indistant metastatic disease.
Okay, so he is strictly localized, albeit locally advanced.
Yeah. As for his medical history, he has well-controlled hypertension, a BMI of 28, and mild prediabetes.
So, you are sitting across from him in the consult room. You have just explained the radiation process, and he looks at you and asks the core clinical question.
He says, "My urologist said I need hormone shots for 2 or 3 years. Why so long? Can the radiation work without them?"
And then he probably adds, I have a buddy who just got radiation for his prostate cancer and he didn't need any hormones at all.
They always have that, buddy, right? That is the pivotal question we face every single week in clinic. And the answer is entirely dependent on his specific risk group.
For the oral boards, you need to have a canned, flawless response ready to go when presented with this exact scenario.
Right. Examiners don't want you to hem and haw or start philosophizing about the nature of cancer.
No, they want a crisp, data-driven defense of your management plan.
I am going to role-play the examinee right now and deliver the 60-second board script exactly as you should recite it. Listen to the cadence and the specific trial references. Okay, here goes.
Let's hear it.
This is a 63-year-old with high-risk prostate cancer, T3A, PSA24, GG4, high-volume disease. He is a candidate for definitive EBRT with long-term ADT of 18 to 36 months. The rationale comes from EORTC 22863, which showed 10-year OS of 58% with radiation plus long-term ADT versus 40% with radiation alone for high-risk disease, and RTOG 9202, which showed at 19.6-year follow-up that long-term ADT improved OS over short-term ADT in locally advanced disease. The NCCN recommends 4 to 6 months of ADT for unfavorable intermediate risk and long-term ADT of 1.5 to 3 years for high and very high-risk disease. For favorable intermediate risk, ADT can generally be omitted. ADT should never be used as monotherapy for localized disease unless local therapy is contraindicated. For boards, no RTOG 9408, ADT benefit only in unfavorable intermediate on secondary analysis, RTOG 9910, no benefit extending beyond 4 months for intermediate risk, EORTC 22961, 6 months is NT non-inferior to 36 months, and the MARCAP meta-analysis, prolonged adjuvant ADT improves DMFS.
Wow. Flawless. Let's break down why that script is structured the way it is. Notice how it immediately categorizes the patient.
Yeah, you didn't just list his stats, you synthesized them into high-risk, high-volume disease.
Right. Then you stated your definitive treatment plan, EBRT, with 18 to 36 months of ADT.
And then, crucially, you fired off the exact justifications. You gave the foundational trial, EORTC 22863.
And you didn't just name drop it. You gave the exact 18% absolute overall survival benefit at 10 years.
Then you brought in RTOG 9202 to defend the duration of the ADT.
Finally, you zoomed out to show the examiners you understand the entire spectrum of disease, from omitting it in favorable intermediate to the specific caveats in the RCAP data.
Having that exact script internalized is completely mandatory.
It really is. But memorizing a script isn't enough if you don't actually understand the underlying mechanisms.
No, you have to know the why. So let's unpack the actual biology and the rationale here. Why do we combine ADT with radiation in the first place?
Right. If radiation is a localized treatment designed to break DNA and cause cell death, why do we need to manipulate the patient's systemic hormone levels?
It comes down to 3 deeply interconnected complementary effects: cytoreduction, radiosensitization, and sustained suppression.
Let's take those one by one. First up, cytoreduction.
So when you start androgen deprivation, you are immediately cutting off the primary growth factor for the prostate tissue.
Yeah, the prostate gland itself literally shrinks, often by 20 to 30% in volume.
From a purely physical radiation planning standpoint, a smaller prostate means smaller target volumes.
Which means less radiation dose spilling over into the anterior rectal wall and the bladder neck.
Right, exactly. But more importantly, cytoreduction is happening on a cellular level to the tumor bulk and to any micrometastatic disease that might be floating in the lymph nodes or the marrow before the radiation even starts.
And that leads perfectly into the second and arguably most crucial mechanism, radiosensitization.
This is where the biology gets fascinating.
By eliminating testosterone, ADT doesn't just starve the cell. It actively impairs the DNA repair pathways inside the prostate cancer cells.
Right. When our high-energy X-rays hit a cancer cell, they create double-strand DNA breaks.
Normally, a cell will try to fix those breaks using a mechanism called non-homologous end joining, or NHEJ.
And one of the key enzymes in that repair pathway is a protein called DNA PKCS.
Here is the critical link. The androgen receptor, when it is bound by testosterone, actually acts as a transcription factor.
It upregulates the production of DNA repair proteins, including that DNA PKCS, right?
Exactly. So when you remove the testosterone, the androgen receptor stays dormant in the cytoplasm. It never goes to the nucleus.
So the cell stops producing adequate levels of DNA repair enzymes.
Yes. So when the radiation fraction comes in and shatters the DNA, the cancer cell reaches for its repair tools, but the toolbox is empty.
The radiation damage becomes permanent and the cell undergoes apoptosis. This is why ADT and radiation are not just additive, they are intensely synergistic.
To make this memorable for your own mental model, or even when explaining it to a savvy patient, think of it like an invading army scenario.
I like this analogy.
Imagine the cancer cells are an entrenched enemy force. The ADT acts on two fronts. It starves their supply lines by cutting off the testosterone fuel, and it simultaneously disables their defensive shields by paralyzing their DNA repair mechanisms.
This leaves them completely vulnerable, making your frontline artillery strike the radiation devastatingly effective.
You aren't just hitting them. You are hitting them while they have no armor and no supplies.
That is exactly what is happening at the molecular level. And then there's the third effect, sustained suppression.
Right. Because after the radiation course is finished, the patient remains on ADT for months or years. Why?
Because we assume that in high-risk disease, some microscopic clones have already escaped the pelvis.
Yeah, they're floating in the bloodstream or hiding in the bone marrow.
The sustained androgen blockade keeps these lingering cells completely dormant. It prevents them from establishing a blood supply and growing into overt metastases.
Eventually forcing them into a state of senescence or cell death.
So, knowing the biology, let's look at the foundational clinical evidence that prove this concept. I want to spend some real time on EORTC 22863.
You really cannot overstate how important this trial is to the history of our field.
Bulla and his colleagues designed this study back in the 1990s. They took 415 men, mostly with locally advanced or high-risk disease.
Meaning they had Gleason 8 to 10 disease, or bulky T3 to T4 tumors.
Right. They randomized them into two arms, radiation alone versus radiation plus 3 years of ADT.
And you have to understand the historical context here. Back then, radiation was often delivered with older 3D conformal techniques.
Yeah, and the total doses were much lower than what we use today, often around 65 to 70 gray.
We weren't routinely escalating to 78 or 80 gray yet. So the local control from the radiation alone was not what it is today.
But the results of adding the systemic therapy were absolutely earth-shattering.
The jaw-dropping statistic that you must remember, the one that changed the standard of care globally, was the overall survival at 10 years.
The group that received radiation alone had a 10-year overall survival of just 40%.
Wow.
But the group that received radiation plus 3 years of ADT had a 10-year overall survival of 58%.
Let that sink in. That is an 18 percentage point absolute improvement in overall survival.
Let's translate that into clinical reality. An 18% absolute improvement means that for every roughly 5 or 6 patients you treat with this combination instead of radiation alone, you are saving 1 life at the 10-year mark.
In the world of solid tumor oncology, finding an intervention that yields an 18% absolute survival benefit is incredibly rare.
It is massive. It proved unequivocally that ADT doesn't just delay a PSA rising. It doesn't just push the disease down the road. It fundamentally changes who survives the disease.
I'm going to play devil's advocate here, though. If we know that ADT has this profound, synergistic, life-saving effect, why don't we just give it to everyone?
Right. Why isn't every single prostate cancer patient, regardless of stage, walking out of clinic with a prescription for 3 years of hormone therapy?
The answer, of course, is the toxicity. The side effects of androgen deprivation are profoundly life-altering.
We are talking about inducing immediate, profound hypogonadism.
Yeah, patients experience severe hot flashes, complete loss of libido, and erectile dysfunction.
But beyond the sexual and vasomotor symptoms, there is a cascade of metabolic changes,
They lose lean muscle mass and gain visceral fat. This leads to insulin resistance.
which can tip a pre-diabetic patient right into full-blown type 2 diabetes.
Their lipid profiles shift, increasing their cardiovascular risk. They lose bone mineral density, putting them at risk for osteoporotic fractures.
And we can't ignore the cognitive and emotional effects, the fatigue, the mood lability, and sometimes severe depression.
Exactly. The toxicity is very real, and it is cumulative. The longer they are on it, the harder it is on their body.
And the longer it takes for their natural testosterone to recover once you stop the drug.
Because of this massive toxicity burden, the duration of ADT must be perfectly titrated to the exact risk group of the patient.
We cannot undertreat because they will die of prostate cancer, but we cannot overtreat because we will severely damage their quality of life and potentially increase their risk of dying from a cardiovascular event.
To master this tightrope walk for the clinic and the boards, we use a mental framework called the risk ladder.
Let's start climbing that ladder. The lowest rung we are going to discuss today is favorable intermediate risk.
If you have a patient in this group, The current paradigm is that you should consider omitting ADT entirely.
This represents a massive de-escalation win for our patients. But how did we get here? For a long time, intermediate risk was just lumped together as one big bucket.
Right, to understand the evolution, we have to look at RTOG 9408.
This was a huge trial that randomized intermediate risk patients to radiation alone versus radiation plus 4 months of short-term ADT.
And the primary result of that trial actually showed an overall survival benefit for adding the short-term ADT.
So for years, the standard was to give every intermediate risk patient 4 months of hormones.
But as our understanding of pathology and PSA kinetics evolved, we realized that intermediate risk is actually two very different diseases.
We started splitting them into favorable and unfavorable intermediate risk based on factors like the percentage of positive biopsy cores and the exact Gleason score.
Specifically distinguishing between Gleason 3 plus 4, which is grade group 2, and Gleason 4 plus 3, which is grade group 3.
And the number of NCCN intermediate risk factors present.
A favorable intermediate patient typically has only one intermediate factor, a Gleason of 3 plus 4 or lower, and less than 50% of their core is positive.
And this is where the pivotal data comes in. The evidence for omitting ADT in this favorable group comes heavily from Dr. Zumsteg's 2020 post-hoc analysis of that very same RTOG 9408 trial.
Supported by work from the Harvard and Dana-Farber groups, notably Dr. D'Amico.
Zumsteg went back and reclassified all the historical patients in 9408 into favorable and unfavorable intermediate categories based on modern criteria.
And the findings were illuminating. When you look at the ADT survival benefit the overall 9408 trial demonstrated, it was driven entirely by the unfavorable intermediate patients.
The favorable intermediate patients derived absolutely no overall survival benefit from the addition of ADT.
In fact, in that specific subgroup analysis, the favorable intermediate patients had virtually zero prostate cancer-specific deaths, regardless of whether they got ADP or not.
Think about the biological implication of that. Why did they have zero prostate cancer deaths?
Well, because a favorable intermediate prostate cancer, say a small volume Gleason 3 plus 4, is a relatively indolent disease.
It grows slowly, and its metastatic potential is low. The definitive radiation obliterates the local tumor.
Any microscopic cells that might exist are either eradicated by the radiation or grow so slowly that the patient will inevitably succumb to other competing risks, like heart disease or a stroke, long before the prostate cancer could ever threaten their life.
What this means in practice is that giving 4 months of ADT to a favorable intermediate risk patient adds all the hot flashes, the fatigue, and the cardiovascular stress, but adds absolutely zero oncologic benefit.
It is all harm, no help.
So moving one step up the ladder brings us to rung 2, unfavorable intermediate risk.
If a patient crosses that threshold, perhaps they have a Gleason 4 plus 3 or multiple intermediate risk factors, or more than half their cores are positive, then the biology shifts.
The metastatic potential is higher, microscopic spread is more likely, therefore short-term ADT of 4 to 6 months is mandated.
The foundational evidence for this is EORTC 22991.
This trial specifically looked at intermediate and high-risk patients receiving dose-escalated radiation, usually around 74 or 78 gray.
They randomized them to radiation alone versus radiation plus 6 months of concurrent and adjuvant ADT.
The addition of those 6 months significantly improved biochemical disease-free survival and clinical progression-free survival.
It established that even with higher radiation doses, this systemic suppression is necessary to manage the unfavorable biology.
But let me challenge you on this, playing the role of a cautious clinician.
Okay, lay it on me.
If 4 to 6 months of ADT is good at clearing out that micrometastatic disease for an unfavorable intermediate patient, my clinical instinct is to want to add just a little more, just to be absolutely safe.
Right, because we know micrometastases are stubborn.
Yeah. What is the harm in pushing the duration to, say, 8 or 9 months? Wouldn't that ensure we really eradicate every last clone?
It is a totally reasonable clinical instinct, and honestly, for a long time, a lot of clinicians practiced exactly that way, tailoring the duration based on their gut feeling.
But we actually have hard, randomized data telling us that this is a mistake.
I'll point you directly to RTOG 9910. The investigators had the exact same thought process you just described.
They took intermediate-risk patients and randomized them to receive either 4 months of ADT or 9 months of ADT, given alongside the radiation.
They wanted to see if extending the duration improved outcomes.
And the result of RTOG 9910 was a resounding negative.
There was zero difference in 10-year disease-specific survival and zero difference in overall survival between the 4-month group and the 9-month group.
The biological takeaway here is that in intermediate-risk disease, the burden of systemic micrometastatic clones is relatively low.
If 4 months of testosterone suppression, combined with the radiosensitization effect during the radiation, hasn't killed those clones, an extra 5 months isn't going to do it either.
All you achieve by extending beyond 4 to 6 months for an intermediate-risk patient is prolonging their misery, worsening their metabolic syndrome, and delaying their testosterone recovery without improving their cancer outcomes one bit.
Let me throw another common clinical scenario at you.
Go for it.
Let's say we have a patient with unfavorable intermediate risk disease, but our radiation technology is phenomenal now. We are using VMAT, we have daily cone beam CT guidance, and we are delivering a highly conformal dose-escalated plan of 79.2 gray to the prostate.
Okay, a very hot, precise plan.
Right. If we are hitting the gland with that much ablative radiation dose, do we really still need the ADT? Can't we just rely on the sheer physical dose to cure the patient and spare them the hormones?
The answer is unequivocally no. You still absolutely need the ADT, and you cannot substitute radiation dose for systemic hormones.
The citation you must know for this is RTOG 0815.
This was a relatively modern trial that specifically asked this question. They took intermediate-risk patients, mandated dose-escalated radiation, meaning at least 79.2 gray, or an equivalent biologically effective dose, and randomized them to either radiation alone or radiation plus 6 months of ADT.
And the results were clear. Even when you obliterate the prostate with nearly 80 gray of radiation, adding the short-term ADT still significantly improves biochemical failure rates.
And crucially, it significantly reduces the rates of distant metastasis. Why? Because of the fundamental limitation of radiation therapy. It only treats what is inside your target volume.
Right. 80 gray to the prostate does absolutely nothing to a microscopic cluster of cancer cells sitting in a periaortic lymph node or a lumbar vertebra.
The clinical pearl here is that local intensification and systemic intensification work via entirely different complementary mechanisms.
You cannot use a bigger hammer on the local tumor to fix a systemic problem.
Which brings us perfectly to rung 3 on our ladder, high and very high risk.
If the patient is in this category, meaning they have T3 or T4 disease, Gleason 8 through 10, or a PSA over 20, the biology is aggressive.
The probability of pre-existing micrometastatic disease is incredibly high. For this group, long-term ADT of 18 to 76 months is absolutely required.
We are talking about the heavy hitters of clinical evidence here. We already did a deep dive, or an in-depth review on EORTC 22863, which established the 18% survival benefit of long-term ADT over no ADT.
But we also need to understand how we establish the superiority of long-term ADT over short-term ADT for these high-risk patients.
For that, we look at RTOG 9202. This trial randomized locally advanced patients to either 4 months of short-term ADT or 28 months of long-term ADT.
And the data matured beautifully. At the 19.6-year follow-up, the long-term ADT arm showed a clear overall survival benefit.
It proved that 4 months is not enough to suppress aggressive high-risk clones. They need years of suppression to undergo apoptosis.
Furthermore, we have the DART 01/05 GICOR trial from Spain.
This trial is critical because it proved that long-term ADT is necessary even in the modern era of dose-escalated radiation.
They used high doses of radiation and compared 4 months versus 28 months of ADT in high-risk patients.
Just like in RTOG 9202, the 28-month long-term arm demonstrated superior biochemical control, metastasis-free survival, and overall survival.
Now, here is a scenario that comes up constantly in clinic, and it is a major trap I see residents fall into during oral boards.
Right, the compromise trap.
Exactly. You are sitting with a high-risk patient. You tell him he needs 2 to 3 years of ADT. He balks. He hates the idea of being chemically castrated for years.
He says, "Doc, I'll give you 6 months of this hormone stuff, but no more. I can't do 3 years."
You, as the empathetic clinician, want to compromise. You think, well, 6 months is better than nothing. Maybe it's close enough. This is what we call the non-inferior trap.
It is a fatal error. And we have specific, rigorous trial data to prove why you cannot make that compromise without explicitly telling the patient they are choosing an inferior treatment.
The trial is EORTC 22961. The investigators designed this as a non-inferiority trial.
They wanted to know if giving 6 months of ADT was not unacceptably worse than giving 36 months for high-risk disease.
To do this, you set a statistical margin, basically saying if the shorter treatment is within this small margin of efficacy compared to the long treatment, we will call it non-inferior and adopt the shorter, less toxic regimen.
But when they ran the numbers, the non-inferiority hypothesis was completely and spectacularly rejected.
The overall survival hazard ratio comparing the 6-month arm to the 36-month arm was 1.42.
The upper confidence limit far exceeded the predefined non-inferiority margin.
What this means in plain English is that 6 months of ADT was demonstrably, statistically worse than 36 months for high-risk patients. The men in the 6-month arm died at a significantly higher rate.
Biologically, this makes perfect sense. High-risk disease has established footholds outside the pelvis. 6 months of suppression simply hits the pause button.
The cells go dormant, but they aren't dead. As soon as the testosterone recovers, those aggressive clones wake up, proliferate, and become overt, lethal metastases.
You need the prolonged 24 to 36 months of absolute testosterone starvation to force those disseminated cells past the point of no return into senescence and death.
Simply put, giving only 6 months of ADT to a high-risk patient is a definitive management error. You are demonstrably worsening their chance of survival.
There is a slight important nuance here, though, regarding the exact duration for high-risk patients.
Right. While 36 months is the classic EORTC standard, is it possible to get away with slightly less without compromising survival?
To answer this, we look to the Canadian trial, Quebec PCS4. This trial took high-risk patients and randomized them to 18 months versus 36 months of ADT.
The findings were very nuanced. In terms of overall survival, the trial did not show a significant difference between 18 and 36 months.
Though many argue it was underpowered to detect a small difference. However, the 18-month group definitely had worse biochemical failure rates, meaning their PSA started rising sooner.
But here is the critical trade-off that matters to patients. The 18-month group had a much faster testosterone recovery time.
In the 18-month arm, the median time to testosterone recovery was about 3.6 years.
In the 36-month arm, it took a grueling 6.6 years for testosterone to recover, and in many older men, it never recovered at all.
Naturally, the 18-month group reported significantly better long-term quality of life.
So how do we synthesize this for clinical practice? The consensus is that 24 to 36 months remains the gold standard for maximizing oncologic efficacy in high-risk disease.
However, 18 months is considered the acceptable minimum duration.
Right. If you have a high-risk patient who is absolutely miserable on ADT, they are profoundly depressed, their diabetes is spiraling out of control, they are suffering unbearable hot flashes, you can stop at 18 months.
Knowing you are providing a highly effective, evidence-based duration, even if it might carry a slightly higher risk of biochemical recurrence compared to the full 36 months.
Okay, let's pivot and dig into some controversies and recent advances, specifically regarding sequencing and field volumes.
This is an area where the data has shifted dramatically in just the last few years.
Historically, the standard practice was almost always to start the ADT about 2 months before the radiation began. We call this the neoadjuvant phase.
You would give them the shot, wait 2 months, and then start the external beam therapy. Let's ask the question, is a prolonged neoadjuvant phase still the gold standard?
To answer that, we have to look at why we did neoadjuvant in the first place. Back in the era of 3D conformal radiation, we needed the prostate to physically shrink so we could use smaller radiation portals and spare the rectum.
There was also a theoretical biological argument that suppressing the tumor's metabolism before the first fraction of radiation would somehow prime it for destruction.
But as our technology improved, with IMRT and VMAT allowing us to paint dose tightly around even a bulky prostate, the physical need for massive cytoreduction diminished.
And more importantly, the biological data started telling a completely different story.
The paradigm shift began with trials like Ottawa 0101. They looked at intermediate-risk patients and compared a regimen heavily weighted toward neoadjuvant and concurrent ADT against a regimen weighted toward concurrent and adjuvant ADT.
The trend started to favor the adjuvant arm. The idea was emerging that the systemic therapy given after the radiation might actually be more important than the therapy given before.
And then we got the massive 2020 pooled analysis by Dr. Spratt and colleagues.
They looked at individual patient data from over 1,000 men across multiple randomized trials. They specifically analyzed patients receiving prostate-only radiation fields.
Their findings were incredibly clear. Shifting the ADT duration to the adjuvant phase, meaning after the radiation completes, was genuinely superior to neoadjuvant sequencing for endpoints like progression-free survival and distant metastasis.
But why would that be biologically? Think about the tumor microenvironment.
While the massive primary tumor is still intact in the prostate, it is acting as a biological sink.
It is secreting growth factors, it is interacting with the immune system, and it is potentially releasing new clones.
If you use up all your ADT time before and during the radiation, you are suppressing the system while the mothership is still active.
But if you shift the ADT to the adjuvant phase, you are applying the systemic suppression after the radiation has shattered the primary tumor.
The primary source is dead or dying. Now, the ADT can focus its entire suppressive force purely on the microscopic, disseminated clones without interference from the primary tumor bulk.
Furthermore, maintaining the androgen blockade during the months after radiation ensures that the paralyzed DNA repair pathways remain disabled while the irradiated cells are attempting to recover, driving them toward apoptosis.
The final nail in the coffin for mandatory neoadjuvant sequencing came from the RCAP meta-analysis by Dr. Kishan and his team in 2022.
MARCAP is a monumental effort that pooled individual patient data from practically every major prostate cancer radiation trial in history.
Their rigorous analysis completely solidified this new understanding. They confirmed that prolonging the adjuvant portion of ADT is what actually improves distant metastasis-free survival.
The neoadjuvant portion, while cytoreductive, does not drive the long-term cure rate the way the adjuvant portion does.
So what is the clinical takeaway for your practice?
If you are treating a patient with EBRT to the prostate alone, a prolonged neoadjuvant phase of ADT is generally unnecessary and potentially delays definitive local treatment without an oncologic benefit.
The modern preferred sequencing is to start the ADT concurrently, perhaps just a week or two before the radiation begins, and then run the bulk of the duration in the adjuvant setting.
Before we leave the topic of volume and fields, we have to touch upon a fascinating interaction between local treatment intensity and systemic treatment duration.
We just spent all this time establishing that you cannot substitute radiation dose for ADT. But what if the local therapy is so intense, so completely ablative, that it alters the systemic equation?
I am talking about brachytherapy.
This is one of the most exciting findings from the RCAP data. We know that a brachytherapy boost, where we implant radioactive seeds directly into the prostate, in addition to giving external beam radiation, delivers an extraordinarily high biological dose to the tumor.
It overcomes hypoxia and eradicates the local disease with incredible efficiency.
When the MARCAP investigators analyzed patients who received a brachytherapy boost, they found something incredible. The optimal threshold for ADT duration in high-risk patients dropped significantly.
For high-risk patients receiving EBRT alone, the data showed the optimal ADT duration was around 26 months or more.
But for high-risk patients who received a brachytherapy boost, that optimal threshold dropped down to just 12 months.
Let me be clear. It does not eliminate the need for ADT. Systemic therapy is still required.
But it means that local spatial intensification, the massive dose of brachytherapy, partially substitutes for a hormonal temporal duration.
By ensuring absolute, rapid local eradication, you cut off the source of metastases so effectively that you can spare the patient more than a year of systemic toxicity. It is a profound example of how local and systemic therapies interact.
Let's shift gears now to an advanced topic that is rapidly becoming standard of care: hormonal intensification.
For decades, standard ADT meant one thing: chemical castration, usually achieved with an LHRH agonist like leuprolide, which shuts down testosterone production in the testicles.
But the testicles are not the only source of androgens. The adrenal glands produce weak androgens, and importantly, prostate cancer cells themselves can mutate to synthesize their own intracellular androgens.
For our absolute highest risk patients, just shutting down the testicles might not be enough.
This is where we introduce the concept of systemic intensification, and specifically the STAMPEDE trial.
STAMPEDE is a massive multi-arm, multi-stage platform trial out of the UK. The specific arm you need to know for localized disease is Arm G.
They looked at patients with very high-risk localized or locally advanced prostate cancer. They randomized them to receive standard ADT plus radiation versus standard ADT plus radiation plus 2 additional years of abiraterone and prednisolone.
We need to understand the mechanism here. Abiraterone is a CYP17 inhibitor. It blocks an enzyme crucial for androgen biosynthesis.
By adding abiraterone, you aren't just shutting down the testicles, you are shutting down androgen production in the adrenal glands and within the tumor microenvironment itself.
You're achieving a deeper, more absolute state of androgen deprivation.
And the clinical results from STAMPEDE Arm G were phenomenal. For these very high-risk localized patients, adding the abiraterone significantly improved distant metastasis-free survival.
At 6 years, it was 82% in the abiraterone arm versus 69% in the standard ADT arm.
And most importantly, it demonstrated a clear improvement in overall survival. We are now curing men who previously would have inevitably developed metastatic disease.
But patient selection is critical here. You do not give abiraterone to an intermediate-risk patient or even a standard high-risk patient.
For the boards and for your clinic, you must memorize the specific STAMPEDE high-risk criteria.
To qualify for this intensification, a patient with non-metastatic disease needs to meet at least 2 of the following 3 criteria: clinical T3 or T4 disease, a Gleason score of 8 to 10, or a PSA greater than or equal to 40.
Let me reiterate that. 2 out of 3. T3/T4, Gleason 8 to 10, PSA 40 or higher.
If they meet 2 of those, they're candidates for intensified systemic therapy with abiraterone.
But you have to weigh this against the added trade-offs. Abiraterone adds significant toxicity. It can cause hepatic toxicity, requiring regular liver function tests.
Because it alters steroid synthesis, it can cause mineralocorticoid excess, leading to hypertension and hypokalemia, which is why it must be given with prednisolone.
And frankly, it adds significant financial cost. This must be a shared decision-making process with the patient.
While we're discussing the actual drugs used for ADT, we absolutely must talk about agent selection. As I mentioned, the traditional backbone of ADT has been LHRH agonists like localized.
These drugs work by overstimulating the pituitary gland, which initially causes a massive surge or flare in testosterone before the receptors eventually downregulate and testosterone production crashes.
That initial testosterone flare is problematic. Clinically, it can cause a temporary worsening of symptoms like bone pain if they have micromets or urinary obstruction.
But more insidiously, that initial surge and the subsequent fluctuations can destabilize vulnerable atherosclerotic plaques in the cardiovascular system.
For a patient who already has a bad heart, an LHRH agonist can act like a stress test they didn't ask for.
Which brings us to a major pharmacological breakthrough: the GnRH antagonists. Instead of overstimulating the receptor, antagonists directly block it.
There is no initial surge. The testosterone levels drop to castrate ranges within days.
The HERO trial was a landmark study that compared a new oral GnRH antagonist called relugolix directly against the standard LHRH agonist leuprolide.
The HERO trial showed 2 massive advantages for the antagonist, relugolix. First, the testosterone recovery was much faster after the drug was stopped.
But the game changer was the cardiovascular safety profile. They looked at the rate of major adverse cardiovascular events, or MACE things like heart attacks and strokes.
In the relugolix group, the MAC rate was 2.9%. In the leuprolide group, it was 6.2%.
The oral antagonist cut the risk of a major cardiac event by more than half. For any patient with pre-existing cardiovascular risk factors, a history of MI, severe hypertension, or diabetes, an antagonist like relugolix is strongly preferred over an agonist.
This is a perfect time to pull all of this complex biology, trial data, and pharmacology together.
Let's bring it all back to our 63-year-old patient from the introduction. You are sitting across from him. He has T3 disease, a PSA of 24, and grade group 4.
And he has prediabetes and hypertension. How are we actually going to construct his treatment plan based on everything we just discussed?
Okay, let's break it down step by step. Step 1, duration. He is firmly in the high-risk category.
Therefore, based on the foundational EORTC 22863 trial and explicitly warned by the EORTC 22961 non-inferiority failure, we cannot give him just 6 months.
He requires long-term ADT of 24 to 36 months to ensure those aggressive micrometastatic clones are pushed into senescence.
Step 2. Intensification. We need to check the STAMPEDE criteria. Does he meet them?
He has T3 disease, so that is one criterion. His Gleason is 8, so that is the second criterion. He meets 2 out of the 3.
Even though his PSA is only 24 and not 40, he qualifies. Therefore, based on STAMPEDE Arm G, adding abiraterone and prednisolone for 2 years must be strongly discussed with him to maximize his chance of a definitive cure.
Step 3. Sequencing. Based on the SPRAT pooled analysis and the MARCAP data, we are not going to delay his radiation.
We will start his ADT concurrently, perhaps just a few days before his first fraction of radiation, and then continue it adjuvantly for the remainder of his 24 to 36-month duration.
This optimizes the synergy without delaying definitive local control.
And step 4, agent selection. We have to look at his medical history. He has well-controlled hypertension and, importantly, mild prediabetes.
These are established cardiovascular and metabolic risk factors. Based on the cardiovascular safety data from the HERO trial, we want to avoid the testosterone flare and plaque destabilization associated with leuprolide.
We should strongly prefer an antagonist like oral relugolix for his primary androgen deprivation.
Now comes the hardest part of our job, the counseling conversation. You have formulated the perfect evidence-based plan, but now you have to look this man in the eye and explain it to him.
You have to balance the incredible, life-saving survival benefits against the very real, life-altering quality-of-life trade-offs.
You have to talk about the hot flashes, the potential for erectile dysfunction, the profound fatigue, the risk of bone density loss, and the worsening of his metabolic syndrome.
You have to build trust. And part of building trust is being brutally honest about the timeline. Acknowledging that his testosterone might not recover for 3 to 6 years after he finishes the treatment is crucial.
If you downplay the side effects, you will lose his trust when they hit him. Having a standardized, empathetic script for this conversation is vital. Here is the exact script you can adapt for your clinic. Your cancer is high risk. It has aggressive features that make it highly likely to spread beyond the prostate if we do not treat it with everything we have. The radiation we are planning will treat the cancer locally in the pelvis. However, the hormone therapy is what treats any microscopic disease that may have already sneaked out into your bloodstream. Historic, rigorous randomized trials have shown a massive overall survival benefit, meaning a much higher chance of you living a long life, from adding long-term hormone therapy to radiation for your specific type of disease. Without it, the radiation alone is unlikely to cure you. We will need to keep you on this hormone therapy for 2 to 3 years. I need you to know that it will cause significant side effects. You will likely experience hot flashes, fatigue, some weight gain, and a loss of libido. These are tough, but they do improve after we stop the medication. The survival benefit, the chance to completely cure this cancer, clearly justifies the difficult course.
That is exactly how you communicate complex oncology to a patient.
All right, let's shift gears and run through some oral board traps and clinical pearls. I'm going to quickly fire off the 3 fatal traps that will absolutely cause an examiner to fail you on the spot.
Listen closely to these.
Trap number 1, reflexively prescribing long-term ADT for favorable intermediate risk disease. This is gross overtreatment.
The NCCN guidelines explicitly allow omitting ADT for this group based on Zumsteg's analysis of RTOG 9408. Because these patients experience 0 survival benefit and suffer all the toxicity.
Trap number 2, prescribing only 6 months of ADT for high-risk disease. This is dangerous undertreatment.
It was formally tested and proven to be statistically inferior, resulting in worse survival by EORTC 22961. Do not compromise on duration for high-risk disease.
Trap number 3, using ADT as monotherapy for localized disease.
Unless local therapy is completely contraindicated due to massive comorbidities or extremely short life expectancy, ADT alone is the wrong answer. It is a radiosensitizer and a systemic sweep. It is not a definitive local cure.
Those are the landmines you have to avoid. Now, let's trade some rapid-fire clinical pearls. I will start. Pearl 1. The duration of ADT is entirely 100% risk group specific.
You cannot guess. 4 to 6 months for unfavorable intermediate, 18 to 36 months for high and very high risk.
Pearl 2. EORTC 22863 is your absolute foundational trial. You must know it cold.
It demonstrated a massive 18 percentage point absolute overall survival benefit at 10 years when adding long-term ADT to radiation for locally advanced disease.
Pearl 3. 6 months is not enough for high-risk disease. As we discussed with the non-inferiority trap, EORTC 22961 definitively proved that 6 months is worse than 36 months.
Pearl 4. RTOG 9408 is a nuanced trial. Remember that the overall trial showed a benefit for short-term ADT, But the specific Zumsteg post hoc analysis is what gives you the data-driven permission to safely omit ADT for the favorable intermediate risk subgroup.
Pearl 5. Sequencing matters, and the data has evolved. The RNCAP meta-analysis proves that the adjuvant portion of prolonged ADT is what actually drives the improvement in distant metastasis-free survival.
This validates the modern shift away from prolonged neoadjuvant-heavy approaches, specifically when treating prostate-only fields.
Okay, it is time for a pressure test. Let's do a quick board blitz.
I'm ready.
I am going to act as the oral board examiner and pose 3 highly specific multiple-choice scenarios based on everything we've covered. I want you to give me the definitive answer and a crisp one-sentence rationale citing the relevant data. You ready?
Bring it on. Let's see if I actually absorb this.
Question 1. A 65-year-old man presents to your clinic with favorable intermediate-risk prostate cancer. He has grade group 2 disease, a PSA of 8, and clinical T1C stage, with only 3 of 12 biopsy cores positive. He is planned for definitive EBRT to a dose of 60 gray in 20 fractions. Do you add ADT to his treatment plan? A, yes, 4 months. B, yes, 6 months. C, no, omit entirely. D, yes, 18 months.
The answer is C, no, omit ADT entirely. The rationale is based on the Zumsteg secondary analysis of RTOG 9408, which demonstrated that favorable intermediate-risk patients derive absolutely zero survival benefit from the addition of ADP, meaning it would only subject him to unnecessary toxicity.
Excellent. Crisp and accurate. Question 2. A 68-year-old man with high-risk prostate cancer, specifically grade group 4, a PSA of 28 and T3 a disease, is treated with radiation and given only 6 months of ADT because he refused a longer course. Based on randomized level 1 evidence, what is the primary oncologic concern with this management? A, 6 months is actually too long and will cause excessive toxicity. B, 6 months is statistically non-inferior to 36 months, so there is no major concern. C, 6 months was formally tested and found explicitly not non-inferior for overall survival, meaning he is being undertreated. D, duration of ADT does not significantly affect overall outcomes in high-risk disease.
The answer is C. The concern is that 6 months was formally tested against 36 months and found not non-inferior for overall survival as proven by the EORTC 22961 trial. His chance of survival is statistically compromised.
Spot on. Last one, question 3. You have a high-risk patient receiving definitive radiation therapy to the prostate only, with no pelvic nodal irradiation. Based on modern meta-analyses, which sequencing strategy is preferred for his ADTA? A prolonged neoadjuvant phase is clearly superior. B, concurrent and adjuvant sequencing is preferred. C, sequencing has no measurable impact on clinical outcomes. D, the neoadjuvant phase should be extended to at least 6 months.
The answer is B. Concurrent and adjuvant sequencing is preferred. This is based on the SPRAT 2020 pooled analysis and the MARCAP meta-analysis, which both demonstrated improved distant metastasis-free survival when the ADT is weighted toward the adjuvant phase for prostate-only fields.
Nailed it. That is exactly how you handle those questions under pressure.
Synthesizing everything we've talked about today, from the basic biology of DNA repair to the complexities of the STAMPEDE trial, I want to leave you with a forward-looking thought.
I love these. Let's hear it.
We talked about how grueling the toxicity of long-term ADT is for our high-risk patients. But as our local therapy technologies continue to improve, with incredible precision-like integrating MRI-guided brachytherapy boosts or ultra-high-dose SBRT, we're seeing early, tantalizing signs in the data.
Specifically via the RFAP analysis, right?
Exactly. We are learning that we might eventually be able to trade local spatial intensification for a reduction in systemic temporal duration.
Imagine a near future where we can safely spare a high-risk patient an entire year or 2 of systemic chemical castration, simply because our local dose delivery is so precise and biologically ablative.
It is a completely fascinating frontier for the field, and it proves that radiation oncology is never static. We are constantly evolving to maximize cure while minimizing harm.
Complete practice oral boards at radoncSmartLearn.com and subscribe to Radonc Smart Review for our next episode. Thanks for tuning in.